I am Dr. Madhav Shinde, cardiac surgeon from Max. Today we'll be talking to Dr. Dr. Ranjit John regarding ECMO and ECMO as a bridge to transplant. So Dr. Ranjit.
My name is Ranjit John. I'm a cardiac surgeon at the University of Minnesota.
And I'm Dr. Rahul Dutta, cardiac anesthesiologist from Max Super Specialty Hospital, and I would be taking through this same session, and we will discuss about what role today ECMO has in acute cardiac emergencies.
So Dr. Ranjit, we have a patient in the ICU. He is a 40-year-old patient. He is a diabetic patient. He has suffered an acute extensive ventricular MI. His LVEF is 20%. He is on inotropes. He is on IBP, but still his hemodynamics are not stable. We are requiring a lot of inotropes. His urine output is dipping. The lactates and the ABG are rising. So how do we go about it now? How to manage?
So in summary, it's a young patient who's had acute cardiogenic shock in the ICU, who's worsening on maximal inotropic and pressors and intra-aortic balloon pump. So certainly I would say that you have to escalate therapy, and probably the quickest form of escalation that will give a maximal support is ECMO. Is the patient intubated?
Yeah, the patient is intubated.
So the next question is, what time of the day it is, who is available to put the patient on. I would say peripheral ECMO is probably the quickest, as opposed to getting the patient down to the operating room.
Yeah, it is the third day post MI, and he is in a cardiac CT-based ICU. So we have a team who's available to put a bedside ECMO. So we can go about it.
And the other important thing is the patient in impending cardiac arrest, because the patient in impending cardiac arrest, by that I'm talking about seconds to minutes, then certainly it's almost like a code situation. But otherwise, if the patient is blood pressure 70s, 80s, we can either put ECMO at the bedside or take him down to the cath lab. So we is quasi-stable and can make it to the cath lab. I would prefer that because the team there has fluoroscopy, and either an interventional cardiologist or a cardiac surgeon with percutaneous skills will put the patient on a peripheral VA fem ECMO, and almost certainly put a reperfusion cannula down the femoral artery. So that would be the next step for this patient. So hopefully another 30 minutes he's on.
And we can also put it in the ICU because we have got like TE support, transcatheter echo, and our anesthetists are quite capable of like locating the cannulae. So what kind of ECMO would you like to put, whether veno-venous or a veno-arterial in this patient?
No, 100% veno-arterial ECMO. Yeah.
And you stress the importance of a reperfusion cannula, right? So the importance is to avoid ischemia to the distal limb, right?
Especially nowadays with the new ECMO systems that are the duration of ECMO support has moved from the 1-3 to the 5-15 day category. So you kind of almost eliminate the dreaded complication of limb ischemia with reperfusion cannula. So and that should be done under either fluoro or sonogram. So you're really in the lumen of the artery with the distal perfusion, and we typically use like an 8 French cannula.
Right.
So would you leave the IBP in after the VA initiation of the VA ECMO?
Yes, I mean in this patient, salvage life first. So put him on VA ECMO, leave the balloon pump, and now the next 24 hours. Is his end organ dysfunction going to improve? Is he going to start making urine? The LFT is going to get better. Is a lactate, which is typically kind of escalated over those last few hours, they go up first before coming down, but is all that going to come for the next 24 hours? VA ECMO, leave the balloon pump, leave everything, hope end organ reverses, and if he's had a cardiac arrest, we'll also check for neurological recovery, but at least this patient did not have a cardiac arrest. So the next 24 hours is seeing whether end organ function gets better.
More emphasis is for maintaining multi-organ to at least slow down or stop the process of further multi-organ dysfunction, and till the time we emphasize more on maintaining good perfusion, hemodynamics, and then we go ahead further with whether we should keep the patient bridge for or to plan for separate things.
Right.
Or initially shall we just try to wait some time, check his neurological status, improve his liver parameters, lactates to come down, inotropes to come down, and then we go ahead.
Yes, I think the next 24 to 48 hours is exactly what you said, reversing the end organ dysfunction. And another important thing to see is, is there pulsatility to get an echocardiogram, usually within 6 hours after the ECMO is placed. And I look for 3 things. Is the aortic valve opening? Is the LV distended? Is there severe MR? If either of those things are there, then it is almost mandatory to vent the LV right away. There are many ways to do that, but the important thing is to do one of those right away and do it as quickly as possible.
So a continuous TE monitoring in such patients would help rather, because to know whether the cardiac stun has happened or not, whether the aortic valve is opening, whether the LV is getting distended up further, and you need to put in something so as to drain it out. Do you use TE frequently in such patients, or does it, like the transthoracic one, is enough?
We haven't done continuous TE, but one of the easy subtle signs that I look for is the A line. If the dreaded finding of a flat A line with no pulsatility is there, you don't need any echo to tell you that that LV is distended. The other thing is a simple chest X-ray and blood gases. If the X-rays show that it's getting whited out, usually that doesn't happen right away. But again, all these signs are there that the LV is distended. And if you want to confirm it, get either an echo, transthoracic. I mean, we're not looking for anything fancy. You're just looking for size of LV. Is it big or small? Is the aortic valve opening? Yes or no? Is there MR greater than moderate? Yes or no?
So anything greater than moderate is something which we have to take up seriously.
I mean, they usually go hand in hand. Aortic valve not opening or minimal opening, LV distended. When you have those two, there is always some degree of MR. You don't, I think the important thing is you don't need all 3 to vent the LV.
Well,
I have been a little slow in getting the LV vented, and I think that's a mistake. I think, even having a policy of venting every LV right away, it might be overkill, but certainly decompressing the LV is only going to hasten recovery.
so
if there's any
as this patient history suggests, he had an acute MI, and usually you don't see that
Recovery,
much LV dilatation happening
right away.
immediately, right? Whereas in those, maybe as you said very correctly, maybe the presence of A line and other things are more important for us to. So sir, what would you like to do for venting of LV in such patients?
So can you enlighten us how do you propose to vent the LV, especially for the viewers, especially if the patient is bedridden in the ICU? So how can we do it percutaneously?
So if there is some pulsatility, I think you can give it some time, 6, 12, 24 hours to see if the pulsatility improves. But if there is no pulsatility, then I think a quick way is to put an impeller 2.5 through the femoral artery and into the LV and position that will effectively drain the LV. For some reason, if an impeller 2.5 is not available, many hospitals all over the world don't have access to impeller 2.5, then one of 2 ways a surgeon probably has to do this: small cut down in left anterior thoracotomy, putting a 10 French cannula into the LV apex, or doing a stenotomy or a mini right thoracotomy, putting a LV vent like you would do for an aortic valve replacement in through the LV via the right superior pulmonary vein. A new technique that's gaining popularity that is to create a balloon septostomy and put the venous cannula, the multi-hole venous cannula into the left side, into the LA, so you're draining LA and RE blood with that cannula. So that's a quick way that can be done. But I think the lessons that we have learned finally is that it is imperative to drain that LV if you want to have recovery. And the other thing many people don't realize is that if the LV is not vented and you're having moderate to severe mitral regurgitation, the other organ that you're affecting is the lung.
So how long we can keep our patient safely on this ECMO?
Yeah. So then that comes to the next step. So once you've reached 24, 48 hours, patients making urine, neurologically awake, end organ functions reversed, AST, ALT comes back to normal in this 40-year-old, I think you have 3 things to do. One is bridge to recovery, and that will depend if the patient has had a massive LAD infarct, troponin has been 200, that anterior wall is very unlikely to come back. Did this patient get stented 2 days ago? Or?
No, the patient wasn't stented. He arrived late.
So they didn't even so that anterior wall is going to be dead. So very unlikely going to be vented. And then I think the next algorithm is either transplant or LVAD. If the patient is a favorable blood group, we think we can get a donor within a week. then I would go for transplant. And to be a good transplant candidate, neurological intact, end organ function reversed, and the patient is, the family says that we will do everything we can to keep him alive, I think I would go with the transplant.
And we'll have to see his PVR for the transplant.
That's going to be hard to check on ECMO. You would think that if this patient had a normal, cardiac function prior to this, and this is an acute MI, unlikely that he's going to have that bad pulmonary hypertension. I would worry about that more in a chronic heart failure patient with a dilated cardiomyopathy who suddenly decompensates, and then I would worry about PVR. This patient is less of a worry, and it's going to be hard to check numbers on ECMO. So.
And then we post him and put him onto the transplant list.
Right.
And I think then if it is like almost 14 days or something, like maybe we are crossing over 14 days and now it is 20 days. So when would you like to change from ECMO to something else, maybe a CentriMag or something?
I think it's important that the teams, based on their experience, the medical teams, the surgeon, cardiologists, critical care teams, decide what's the magic number. There's no magic number, but I think once we get into that 7, 10, 2-week period, patients lying in bed on VA ECMO,
They tend to become septic and all.
you start, the complications from ECMO start mounting. I would think a safe time is about 7 to 10 days,
7 to 10.
probably on 7 more than 10, that we get a heart, and if we don't, then we would either go for an LVAD if the patient can afford it and the family wants it, or then go to CentriMag and then wait longer. The advantage of the CentriMag is hopefully by now lungs are recovered, you can take the oxygenator out. The downside of the CentriMag is that it has to go to a central system, though there are some innovative percutaneous techniques. How about this? One way to do that is if patient doesn't want LVAD or cannot afford it, we don't think we're going to get a heart transplant and he needs longer support. One of the things that we have done is transition peripheral VA ECMO to subclavian impeller or even a subclavian balloon pump. I know balloon pump didn't help that patient earlier, but now, subclavian balloon pump or a subclavian impeller 5.0, you get 4.8 liters of flow. It's like an LVAD. It's peripheral. Patient can be, if he's intubated, he can be extubated. If he's already extubated, he can walk, eat, and you can wait weeks on this.
Apart from the one preparation for the heart transplant, what should be the routine? Like we should keep on checking that he's not developing any of the new complications from the ECMO which has been initiated into.
So if you look at the 3-4 big complications, one is limb ischemia, and that's been eliminated with your reperfusion device. The second one is neurological, so you maintain adequate ACTs, and that's all you can do on ECMO. You hope for the best. We often say the first big complication on ECMO is often the patient's last. So if you have a stroke and it's the end for that patient. And the third one is infectious complications, which are often attributed to the patient being in an ICU in well-being line. So you have to give some sort of prophylactic antibiotics. That's why by around 5, 6, 7 days, if a heart transplant doesn't look imminent and it's not going to happen within a day or two, patient can't get an LVAD, permanent LVAD for any reason, I would say to switch to a something like a subclavian impeller. Because or to a central CentriMag, but that's requiring going into the chest.
Dr. Ranjit, how important is the RV function in these patients? And we have like modalities like nitric oxide and like other things so that we can control the RV pressures and we can decrease the PVR. So
luckily in this subset of patients with acute cardiac shock from myocardial infarction, typically their RVs are okay in these patients. Unlike the myocarditis patient, those patients, the ones that come with like giant cell myocarditis or an idiopathic myocarditis acute from a viral illness, those patients, the RV is extremely poor and they are not good LVAD candidates. But in this prototype of patient with myocardial infarction, from an anti-wall MI from LAD occlusion, their right ventricles are typically spared, hence PVR is not much of an issue. So these candidates are usually good for transplant. They may not be that good for LVAD, as something you mentioned, for permanent LVAD you mentioned earlier, because their LVs may not have dilated by a week or so. They're still
LV cavity is small.
They're still about 5.4, 5.6, which is barely adequate. But if they are under 5, then I would say an LVAD is not a good,
So what kind of LVAD would you like, would you prefer in these patients who have got small LVs? Maybe a HeartMate 3 or a...
I would say the HVAD is a smaller smaller pump, and the cannula is just by a little bit slightly smaller profile than the 3.
Right.
So I think going with an HVAD is
would be better. Right.
So what I summarize is like we initiated him with when we found him in an acute cardiogenic shock. We initially started with IBP and inotrope. He was not getting stabilized. We put him initiated on a peripheral VA ECMO, and somehow it got optimized on this VA ECMO, and we kept him on VA ECMO, observing him for next 48 to 72 hours, hoping that there is improvement in his multi-organ dysfunction which has set in. We check him neurologically, as he is an acute cardiogenic shock.
And he never got intubated, so he is awake.
He is awake, and his liver functions, renal functions are okay, his perfusions are good. So he forms a good transplant candidate. Had he been we take in another subgroup of patient. He is a poor LV patient who has been repeatedly coming to the hospital with frequent complications of heart failure. He has been in ICU. Many times he had been on inotropic support. This time he walked in, he had an VF, we defibrillated him, he reversed, we intubated him, put him neckline, put him an IBP, gave him inotropes. He is like still but in suboptimal, he is maintaining suboptimal cardiac output. What do you think should be now? Shall we again try to bridge him with a VA ECMO? And
so the big difference with this patient is the previous patient had 3 pathways: bridge to recovery, bridge to transplant, bridge to LVAD. In this patient, you can say the bridge to recovery is out. So if you, he needs either transplant or LVAD. And the question is, in the previous admissions that this patient has had, have we broached the topic of LVAD?
Yeah.
And if yes, and let's say he said, I can't afford it, or I never want this drive line, he's a transplant candidate. So in him, I would do the same thing. If he's worsening with balloon pump and inotropes in the ICU, go back to the old, VA ECMO peripheral and list him for a transplant. But before you accept the heart, I would still give that 24 to 48 hour period after initiation of ECMO to make sure neurologically they're awake, no limb ischemia, end organ functions doing well, because when you go for a transplant, patient does well when you go into the transplant with good end organ function as opposed to anuric and AST, ALT in the wrong direction. So in this patient is either a bridge to an LVAD or a bridge to a transplant. And I would say the other option, this patient before VA ECMO, because we know he's not going to recover, is the subclavian balloon pump, or a subclavian impeller. The big difference in this with that is he can get up and walk, and he's going to get good cardiac output especially with the impeller, and he can wait weeks for a heart transplant. So I think slightly different algorithm, but the first step is still the same. Do they need something quickly? Are they imminent risk of dying, or are they having worsening end organ function? The answer is to any of them is yes. Peripheral VA ECMO, either at the bedside or cath lab.
so in a way we can say that VA ECMO today stands as a treatment or a clinical modality of choice for acute decompensated heart failure, and maybe it does provides you at least to a time to where you can plan for future things or future treatment to the patient.
I think you said it perfectly. It's come as a mainstay modality for acute cardiogenic shock, intermax 0 to 1 who's worsening, and just gives time to sort out things, at least that 48, 72 hour period before. And if there is one key thing about the institution of VA ECMO, is to do it before the patient arrests, because once they arrest, then you have another complication of brain injury that you can't predict. So,
Dr. Ranjit, in which condition would we prefer a CentriMag over an ECMO? If the patient is having biventricular dysfunction, maybe then?
I think if you're in the operating room, post-cardiotomy shock or post-transplant, I think with an open chest, the CentriMag has a higher role to play, than
especially in a setting of a biventricular
dysfunction. Yeah.
Because then we can also support the RV.
Yep. And if you can get to the operating room.
Suppose our patient of acute MI develops a biventricular dysfunction, then we'll have to go for a BIVAD rather than a VAD, right?
Yep.
Thank you, sir.
Yep.
Thank
Thank
you
you
for
very much.
enlightening us
Appreciate it.
about the
Thank you.